Hi, my name is John Ash. I'm the Director of Patient Flow. Patient flow within the region is a certainly strategic priority for the region, as well it's a provincial HOSHN. We have implemented a patient flow program which identifies 7 key elements or priorities which we know through best practice need to be developed in a robust way in order for us to have good patient flow across the entire continuum of the patient's journey, and that's from primary health care, the emergency department, into acute care, and then obviously back out into the community. Regionally, we've established a number of priorities for this year, and they deal with activities pertaining to governance, which are, we were implementing a patient flow visibility wall, improving or developing service line pull capacity plans, which identify the steps that each service line takes in order to ensure that they're managing their capacity appropriately. We're also doing work in care coordination, looking at implementing accountable care unit, which is a model line approach on how we're going to provide the best care to our patients. We're also looking at improving how we report data to allow for the various service lines to be able to identify patient flow and the improvement activities where they can focus their Kaizen work. Much of this work is in support of the patient flow framework that I spoke of. And we've received funding from the province to enable a number of initiatives to take place. Some of those initiatives are taking place within the patient flow program itself. However, many of them are within the continuum of the overall journey of the patient. So we have some funding that's going to be focused on activity related to primary health care, as well as in the community, whether that's long-term care or home care. And certainly the executive directors will be speaking on that. As I mentioned earlier, one of the key initiatives is our patient flow visibility wall. The main focus of that is to look at, align with the provincial HOSHN and the metrics that are identified within the HOSHN. And what we are doing is we will report out every 2 weeks. The vice presidents of each of the service line has accountability for improving patient flow. We've identified key metrics that they'll report out on. What's important to note is that the metrics we've identified at the wall will be connected directly to metrics that are on each respective VP's service line wall, and connected to the metrics that are on each of the unit walls. So in the visual that's coming up next, you'll see how each metrics connects to each other, so the units that are working the front line will be able to see the activity that they're doing each day, how it contributes to achieving the overall metrics that we've established from the patient flow, and really about how we are able to move forward to create a system that improves the flow of patients as a whole. It's important to note, as I've mentioned before, that patient flow is our collective responsibility. And to that point, certainly the executive directors that you'll hear from next are going to talk about some of their key areas that they are going to be advancing over the next year. Thank you.
Good morning. My name is Sheila Anderson. I'm the Executive Director of Primary Health Care Urban. Primary Health Care is certainly committed to providing client-centered, community-based, and team-delivered primary health care services. We're really focused on realigning our current services so we can better provide care out in the community closest to our clients. So really delivering on that concept of right service, right provider, and right place. As you know, the primary health care system and primary health care services are certainly the front end, both the front end and the back end of our primary health care system. We currently, all the work that we do is focused on preventing unnecessary visits to the ER, unnecessary admissions to our acute care system, and really trying to pull people back out to the community as quickly as possible. So we are a driver in the ED-WAIT and patient flow HOSHN. Some of the specific initiatives that we're working on this year that will help with the HOSHN, we're in the process just of expanding our services of our assessor coordinators, our acute care assessor coordinators. Those are the folks that work in the hospital that facilitate discharge planning. So we're looking at having them on weekends and on stat holidays. So that work is just getting off the ground. So really helping to facilitate discharges 7 days a week. We're now been reporting on our rural bed availability, so the number of bed days that we have available or the number of beds we have out in our rural facilities, and matching them with our folks in the acute care tertiary centers who have rural addresses, and looking at how quickly we can optimize and get them back to rural beds if that's the best place for them. So really thinking and acting like one. We have a number of our community-based teams that are looking and working with specific clients who have a high dependency on our acute care system. Those are clients that we think we could serve better if we connected our services, our community services to them, and serve them differently out in the community. Recently, we've just had a Connecting to Care team that's just been established that's looking at some of our most vulnerable people and ones that have a very high reliance on our acute care system, and how we can get them to how we can support them differently out in the community so that we can keep them out there and out of the ERs and out of an acute care bed if possible. We also have a community IV therapy program. So currently we know that we have a number of folks that still come back to our emergency room for IV therapy. And we're looking at how we can strengthen our IV therapy program in the community so that we can provide more follow-up IV treatments in people's homes or at our treatment center that's related to our home care. We continue to strengthen our home care services. There's a lot of demand on our home care program, but we're looking at ways that we can become as efficient as possible out in the community to optimize all of our provider time so that we can meet the demand coming out of our acute care system. And we're just about to launch a new program that's part of the Seniors Home First program. It's a provincial initiative where we're looking at having some community nurse practitioners that can provide another layer or scope of practice out in the community that can respond to. They will work closely with our home care folks to see how we can, again, perhaps prevent some unnecessary visits to our emergency room and subsequent acute care stays. So those nurse practitioners will be in the next few months starting to respond to some needs out in the community differently than we have in the past.
I'm Lori Carlson, the Executive Director for Mental Health and Addiction Services. For those of you that don't know, mental health is actually a service line in the health region, and for the past year we've actually had HOSHNs that are related to outpatient wait times for core services and psychiatry, and of course our services included in the ED wait times. In addition, we also have a 10-year mental health and addiction action plan that was just announced by the government in December. So we're anxiously awaiting to hear what that brings us for the new budget year. In order to address flow, we've really tried to move to a balanced care model so that we balance the amount of time that psychiatrists spend out in the community seeing patients and spend some better dedicated time in the hospitals, and perhaps even have a consultation liaison team which would help the other units in terms of getting consults sooner to get patients through. Of course, in addition to this, we also are trialing the demand capacity flow protocol. So we will be going live with our weather boards on our unit in the next couple of weeks. We've already trialed opening overcapacity beds and trying to reduce our time for pulling patients from the ED. So we do a lot right now in the emergency department. We actually have a psychiatric nurse in the department. Our physicians also round twice a day to move patients out, and we do staff our admit no beds in the emergency department. One of the biggest differences I would say in mental health and addiction services is our attitude toward patients, which is the patients in the emergency department are our patients. They're not the emergency room patients. And in fact, our doctors would say that it's more about a failure of the system as to the reason why most patients show up in the ED. So that's why we take that quite seriously. And as you well know, our patients aren't well served in the emergency department, and they are disruptive because they're often vocal and mobile at the same time. The other initiative that we have going on as part of the emergency department wait times is the PACT team. That's the police and crisis team, which was funded under ED Waits. So we're looking forward to getting moving with that project in the new year. And that's it.
Hi, my name is Lori Hopfoff. I'm the Executive Director of Medicine Inpatient Units within the Medicine Service Line here in the Regina Qu'Appelle Health Region. The work that we're going to do over the next year to deliver on the provincial HOSHN will be to meet our goal of 95% occupancy and 0 admit no beds within both of our sites at the Pasqua and the Regina General Hospital. And in order to deliver on this goal, we know that we will need to continue to work on our capacity and our demand, and we will need to continue the work that we're doing inside of the D system and the work with our production boards. And for us, we know a big part of that is the plan of care for the patient. So we will be continuing to advance the care of our patients, to remove the barriers, and get our patients to a safe and a timely discharge. We also are moving to multidisciplinary rounds at the bedside because we know that's most effective and the safest for our patients, and it helps to advance the care, talk about the goals and the barriers to care in real time with a multidisciplinary team. So that's our work over the next year. We've currently got 4 of our 6 medicine inpatient units moved to that bedside round. However, they're still at that infancy stage, and we're continuing to work on that and pull our physicians into that model as we move to the bed map within the Regina Qu'Appelle Health Region. We've got a deadline of March 27th of this year to begin to deliver on that bed map and aligning physicians and services to a nursing unit and a nursing care team. We know that will be helpful for us in terms of communication. It will build relationships within providers. It will be more seamless for us in terms of being able to communicate with our families, the plan of care, and it'll also present our providers, our physician partners, from having to move around to several different units. So we're really looking forward to that. The other piece for us is incorporating a hospitalist model, a service model, and as such we will be the pilot area as the accountable care unit on 4A at the Pasqua Hospital, and that'll be something that we'll be doing in concert with the provincial work that's going on, and we will be one of the pilot sites for that. So we're quite excited about that and looking forward to that as well. The last and final thing, I guess, in terms of this report out is incorporating our line of sight and the metrics and the specific things that we're going to do around a corporate level, a medicine service line level, a program level, and a unit level. We're going to begin to design and articulate those metrics in that line of sight to delivering on our goals. So for example, we'll want to look at the number of patients that have a daily care plan. We'll want to look at the number of patients with a targeted date of discharge. We'll want to look at patients that have a discharge before 11 o'clock. And we'll want to do those things inside of our units and begin to capture that data and report on those daily within our units and at a program level for medicine inpatient units. The other thing that we'll start to do from a flow perspective is to begin to get some focus on our pull times, which is our obligation to pull patients out of emergency once our bed is cleaned within 30 minutes. So those are some of the things that we're planning on focusing on over the next year, and we're looking forward to the work.
Critical care occupancy and cardiosciences occupancy is really based on a fundamental fact of 85% occupancy rate. From a critical care standpoint, we've done a number of things to try to ensure that we can maintain that occupancy. In the surgical intensive care unit, the operating room slate is really our driver to help initiate flow within that patient area in surgical ICU. As patients are slated for critical care, there is the ability to ensure that we have a known demand on each given day, on top of the unknown demand that happens from traumas or other critical care emergencies that come through. In the medical intensive care in the ICU at Pasco Hospital, we have done some work with RPIW number 36 that really looks at our transfer process and subsequent flow into our medical inpatient units. With some of the challenges currently happening in the medical inpatient units, we have had difficulties in terms of managing that flow. And what tends to happen is patients are transferred out later on in the evening or overnight, which from an evidence-based standpoint really suggests that there are risks to patients as well as risks to communication handover. We do have a Code Blue policy and do have an overcapacity bed within the surgical ICU, which allows us to expand if need be, if there was an emergency and we were not able to achieve our 85% occupancy. January 8th of 2015, the Cardiosciences program developed a new physician model with a cardiologist being on service. The cardiologists have two separate areas of responsibility. One physician is a service model in CCU and consults. The second physician is responsible for CSU and 3F. Both of these areas have mimicked the intensive care units as being closed units with any admissions, patient management flow, and discharges being directed through the cardiologist. We're very anxious and have seen some really good results with this service model in the first 3 weeks, and we believe it will help us in terms of obtaining our 85% occupancy in this area as well.
Hi, I'm Sandy Eitner, Executive Director for Surgical Services Line, and patient flow is very important to us. The last few years we've been very focused on reducing our surgical wait times, and along with that we've looked at our post-op length of stay, especially for the orthopedics and for the joint replacements. So we have made some improvements with that. Are we where we want to be yet? No. But we've done a fairly good job with that. But however, it's now time we have to spread our wings and look at other areas where we can improve our length of stay. So the bed allocation methodology team, they came and they looked at a lot of data and they said that we could improve our pre-op length of stay by 2.7 days. And initially we thought, no, that can't be right. But actually looking at the data, it is. So we're looking at urology and orthopedic patients. And what it is emergent and urgent patients that come into the hospital and they're in a bed and they're waiting for their surgery. And so for two reasons. We want them to get their care sooner, but if they're not getting their care, they also are preventing other people from using that bed to get their care. So what we need to do is look at some PQA data, look at what's preventing them from getting their surgery soon enough, and what we need to do to change that. So that's what we're going to be concentrating on. Thank you.
Clinical support portfolio has a number of areas that contribute to enhancing patient flow. One of those is respiratory services, who works a lot with COPD rehab patients. Diagnostic imaging continues to work on improving their turnaround times with same-day service. The lab has reorganized how the phlebotomists are assigned to ER in response to the ER flow. And they've also dedicated some equipment to doing inpatient work, so their turnaround times have markedly improved. Therapy services, as of the February 2nd date, they've eliminated the need for a physician referral in most cases for therapy services, so that avoids delays in waiting for a physician's order. Housekeeping meets benchmark turnaround times pretty much for all of their bed cleans and their bed turnarounds if discharges are entered into the electronic bed management system appropriately and in a timely fashion. If not, the whole system falls apart. So please encourage your people to enter them in appropriately and follow the standard work. Pharmacy does medication reconciliation on admission with pharmacy techs. Patient flow has a huge role to play, and John Ash has already spoken about those. And lastly, Healthline contributes through their pooled referral process.
Good afternoon. My name is Greta Lynn L., and I'm an Executive Director with FacilityBased Continuing Care, which is part of the Integrated Health Services of Regina Qu'Appelle Health Region. Now, although the name of our portfolio has had many changes, our objectives have remained the same. One of our primary objectives has been and continues to be supporting the appropriate use of acute care beds. To that end, we have developed a number of long-term care community-based programs, such as the Quick Response Unit, Convalescent Care Beds, Transition Unit, and Orthopedic Convalescent Service. These have all been under the able and visionary leadership of Sue Neville, which has continued through our other senior leaders, Val Hunko, Karen Earnshaw, and currently Michael Redenbach. Flow through the acute beds is negatively affected if people who no longer have acute care needs are occupying acute care beds. And this can happen for a variety of reasons. Sometimes a patient is nervous about returning home, particularly if he or she is living alone, and they need some time to make decisions and make arrangements if they are looking at alternate accommodations. At other times, the patient is going home, but the house might need some structural adjustment. They may have to build a ramp to avoid the person going up and down steps if they can no longer do that, or they may have to remove carpeting, which can make it very difficult for an individual who now has to use either a walker or a wheelchair to get around. And other patients who would do well in an assisted housing or assisted living option simply cannot afford the cost of places like the Bentley or Victoria Estates. Thankfully, due to the funding that's available now to support the Patient Flow project, we are able to offer subsidized assisted housing by partnering with Much More Lodge. So through this partnership, we will be able to offer for up to 14 residents subsidized accommodation in a facility that is very comfortable and very welcoming, and that supports the person remaining in the community for as long as possible. It is not a personal care home, and persons who need assistance with some of the activities of daily living will make those arrangements through home care. Much More Lodge is probably one of the best kept secrets in Regina. It offers 3 meals, 3 snacks, light housekeeping, weekly deep cleaning. They provide the furnishings, the bedding, the towels, there's Lifeline, there's someone on site 24/7 should an individual run into problems and require either family attention or a trip to the hospital. In this respect of subsidizing assisted housing, I believe Regina Qu'Appelle Health Region is on the leading edge for the province. I'm not aware of this having been done in other places, and although we're only beginning with subsidies for 14 persons, we are hopeful that this is the beginning of something that will only get bigger and better.
Long-term care is pleased to be part of the Supporting Patient Flow and Reducing ED Waits initiative. We in long-term care believe that we can have an impact on reducing the number of transfers from our facilities into the emergency department, thereby allowing those patients who require that service to be able to be seen more quickly. Pioneer Village is home to 390 residents who require long-term care placement. We have about 250 transfers to the emergency department every year, mostly by ambulance. Of those transfers, almost half of the people return to the facility without admission. 40% of those transfers occur by contact with on-call physicians after hours who have very little familiarity with the patient. And 25% of those people that come back without receiving a treatment or another initiative, meaning that we transfer them without any outcome for them medically. We see that there's opportunity to reduce these transfers by about 25 to 40%. By improving assessment and treatment options within the care home with the use of a nurse practitioner, we believe that we will be able to provide patient services within our facilities and thereby provide a more comfortable environment and reduce the risk and the anxiety and stress associated with transfer for our patients. The initiative at Pioneer Village is the inclusion of a nurse practitioner into our care team. The nurse practitioner would work closely with physician services, nursing services, and pharmacy services, and work towards reducing those unnecessary transfers to the emergency department. We want to have supportive and timely care on-site within our long-term care facilities. The position would provide on-site clinical assessment and treatment to the full scope of practice of the nurse practitioner, including prescribing orders. In addition, priorities include mentorship and critical thinking skills development with our unit nurses, including some work on assessment skills. Development of standard work around decision-making tools, care planning and treatment protocols, and a strong focus on hydration and management of key infections are important for this initiative. We are planning on developing an assessment tool to be completed prior to any contact with an on-call physician and an algorithm to assist in determining the appropriate medical intervention. Standard work to establish a common understanding of non-urgent, urgent, and emergent medical needs and processes necessary to support how we move people through these processes will also be developed. Finally, standard work around preventative measures and appropriate interventions based on best practice, particularly around hydration and continence in long-term care, is also key. We believe that by prioritizing these areas of work and the care needs of the residents, we will improve the health and life for our residents and reduce the number of transfers to the emergency department. Metrics are being developed that will include looking at the reduction in transfers to acute care over time, reduction in transfers for very specific conditions like rehydration and infections, and implementation of care pathways to support those preventative measures necessary to reduce transfers for those very common medical conditions. The planned start date for the position is March 2015. We continue to work with our care team partners on the development of the scope of that work and how we will work collaboratively with physicians and pharmacists and nurses to provide the best care possible.